lunch. I would love to tell you that these are rare, but I have a kid with this condition. Nearly everyone we're going to talk about, I have at least one patient. I have several Downs kiddos that I take care of. So you, more than likely, if you're going into family practice or some type of surgery or peds, you're going to come across these syndromes. And even if you're in ortho, a lot of these chromosomal issues are going to be seeing you for their orthopedic problems. So I feel like this is very relevant information no matter what field you go into, because chromosomal problems affect so many areas of the body. I want to stand and walk around. Okay, look over these real quick. Get familiar with the names. Okay, we good? Yeah, heard some of them? Okay. Okay, so let's talk about prevalence. In the U.S., every 3 minutes a baby is born with a birth defect. That's a lot. 17 babies die each day due to a birth defect. More than 1 in 5 total infant deaths are due to birth defects, so 20% of infant death. Birth defects are the leading cause of infant mortality, with 20-25% perinatal deaths due to lethal birth defects. So this is big, and this is not something, I mean, people would argue with me, but I would say something like type 2 diabetes, yeah, it's going to change your life and it can cause complications. You can't escape complications with chromosomal abnormalities. Type 2 can be managed, chromosomal stuff, can't manage it very well. Okay, let's define some terms here. Malformation is a single birth defect from an altered genetic or developmental process. Disruption is more of an abnormal structure of an organ or a tissue, and then that cascades, you can get more abnormal effects from that. Deformation, that's an abnormal mechanical force. So think mechanical force, think in utero stuff. Think too much or too little amniotic fluid. Polyhydramnios can cause some weird shaped heads. Think sometimes the umbilical cord gets wrapped around a limb, can cause some agenesis or some weird development. That's deformation, not chromosomal typically. Dysplasia, abnormal organization of cells into a tissue. You guys are probably familiar with that term, thinking like cervical dysplasia. So that's more of a cellular level. Associations, these are multiple abnormality type terms. Associations are malformations that occur together more frequently than you would expect by chance alone. You start to see something like that, you start to think chromosomes. Sequences, that's the cascade of events, some initiated by a single primary factor, like often a single organ malformation, say thyroid, pancreas, something that is going to control multiple things down the line. That's what we call a sequence. And then a syndrome, Down syndrome, consistent and recognizable patterns of abnormalities from a known genetic cause. Okay, everybody good with those terms? All right. So here, I'll give you my speech, because apparently this makes an impact, because both of my students that I just had rotate with me were like, I remember you telling us. Okay. So there is a ugly term in pediatrics. Have you guys heard of an FLK? Yeah. You heard that term? I hate that term. Oh, it makes me want to cry thinking about it. FLK, it stands for funny looking kid. And any parent that hears you call their kid FLK will be broken for the rest of their life, and they will never see their kid the same way. Okay? So this is how strong they feel. Don't ever call a kid an FLK, ever. Kids are kids. I mean, you know, kids with Down syndrome, I'm glad that you guys know them because they're so wonderful. They're joyous, they're exuberant, and they bring so much joy to people's lives. They are not an FLK. No kid should ever be called that. Nope, no adult should ever be called that. So when you are in the nursery and you're seeing a kiddo and there are some visual abnormalities that you're concerned about, the important factors to remember are talking about family history, prenatal and perinatal history, especially talking to mom. Did you have to take any medicines while you were pregnant? Did you have any infections while you were pregnant? Did you travel while you were pregnant? Did you use any alcohol maybe early on in the pregnancy, like before you knew you were pregnant? Do you have a history of any type of drug use, pill use? A lot of people, you think drugs and they're like, oh, cocaine and heroin. No, I've never done that, but I sure do use a lot of benzos. You got to think that kind of stuff too. You have to be very specific in your questioning when you're talking to these parents. And then you're going to do a workup, obviously. So you're going to run a bunch of imaging, get chest and abdominal x-rays. What may look abnormal on the outside very likely could have abnormalities on the inside too. Okay? Lab studies, so there's several type of chromosomal studies that you can think about. If you're considering a syndrome that is like a genetic mutation like Downs and you just want to get a karyotype, that test is much, much cheaper than, say, if you're looking for a more distinct chromosomal abnormality and you are needing like an entire chromosomal microarray. Very different tests. So have your differential and know what you're testing for. Don't just throw those orders in. I mean, I know a lot of times when we kind of are looking in the dark, we'll throw orders in for CBC, CMP, TSH, G4. You know, you kind of have your like standard repertoire of stuff you may just order just to be looking. These are not tests that you take lightly. These are super expensive tests. Chromosomal microarrays could be like $17,000 and they take a couple of months to get back. So they have to send them to typically Atlanta to get them done. So be very considerate of the parent's financial situation, or if there's sooner care, of the taxpayer situation when you're thinking about ordering these tests. And then also, this is going to be lifelong medical management and genetic counseling to help monitor these kids as they grow, and then as they enter adulthood, if they're thinking about having kids of their own, then genetic counseling really needs to play a part. Genetic counseling also needs to get on board early on in case parents decide they want to have more children to assess that kind of risk. All right, so let's start by talking about the abnormal number group. So abnormal number, we start, the most common one is trisomy 21, commonly called Down syndrome. It's common, 1 in 760 live births, that is common. And with fertility treatments these days, maternal age is getting older. You know, the first time moms have a baby, and we'll talk about it in a second, but the older maternal age you see, the higher the incidence of Downs. So I have a feeling as you guys are coming into practice, you're going to see more and more babies born with Downs. Interesting statistic, 2/3 of Down fetuses spontaneously abort. So if we've got that many babies who are being born alive now, think of how many miscarriages are probably due to a trisomy issue. And that's an interesting point too. When you're thinking about spontaneous miscarriages, people who do not have the privilege of having a medical background do not understand why people miscarry. 1 in 5, did you know that? 1 in 5 pregnancies end in miscarriage. So when we have this beautiful knowledge of understanding, we have to start as a single cell, and millions and billions of replications have to happen perfectly and form tissue structures and organs. We understand, it makes sense to us. Well, yeah, if that doesn't go right, then that's not going to be a viable fetus, and you know, the body takes care of it. But parents don't understand that, so you kind of have to explain it and give them something logical to hold on to in that time. Once they've gotten over the initial shock, it is not the time right away to start explaining, no, don't do that right away. But when, especially in peds or in family practice, if you have someone that is suffering from grief from a miscarriage, hearing this logically can help them so much. So think about that as you're being a provider. How are you going to counsel somebody that is struggling with miscarriage? And sometimes recurrent miscarriage, that's even harder to counsel. Frequently associated with advanced maternal age, we talked about. 25-year-old has a 1 in 1,600 risk, over 40, 1 in 80. Oh my gosh, that's terrifying. Which leads me to this slide. Every female childbearing age knows this slide, and in my case, pushes it in their husband's face to say, look, it's not okay for us to wait and have babies, this is what happens. Anyway, so there you go, maternal age on your horizontal axis. After that, 25 to 30, look at that exponential curve, whoop, shoots up. So I'm turning 31 in a couple of weeks, and my husband is like, maybe we should wait a few more kids to have a baby. And I'm like, no, there's a problem with that. And that's something important as a provider to recognize as well. And maybe as a PA student, if you guys are thinking about having kids, that not just Down syndrome, but generally if you look at any chromosomal abnormality or birth defects, the curve trend seems to be pretty similar. After the age 35, the risk increases drastically. So that's something to counsel your patients about as well. If you're doing your PCP and you're counseling a 20-year-old female, she's going to medical school, and she wants to be on birth control, and she wants a Mirena that's going to last her 5 or 6 years. Sit down and realistically talk with her. When do you think you're going to be married, and when do you want to have a baby? Because that helps determine a lot of health factors, and contraceptive options for females too. All right, let's talk about some clinical features. I'm sure at some point you guys have all seen somebody with Downs, so let's talk about it from a clinical medical standpoint of what kind of things you document on a newborn exam if you saw some abnormalities. Okay, so very flattened faces. They don't have the nice round, like if you look at your neighbor in profile, we have kind of a rounded forehead and our chin sticks out, our mouth comes out. Downs kids are really flat, and I'll show you that in a second in the next slide. Ears. I want you to start remembering, abnormal ears are a very common chromosomal thing. If you see funky ears on a baby, you better be getting workup. Something's not right. Low set and folded pinnae. Have you seen, they got the little flat ears like that? Okay, the upward slanting eyes, they have kind of weird palpebral fissures. Large tongue, what's our term for that? Ooh, good job, guys. All right, and then these cool little things, you can see this little baby's blue eyes here. Those, do you see the kind of grayish dots in the iris all around? Those are called brush field spots. Those are most common in Caucasian babies, very rare in Asian and African American babies, but they're a very good indicator of some type of a chromosomal abnormality. It's a connective tissue deposition. It's kind of little clumps of weird connective tissue in the iris that typically aren't there. And Downs causes a lot of other connective tissue problems. So the little picture there, you can look over heart problems, large colon, widely spaced toes, funky short fingers, and we'll get to those in a second. Okay, so newborn features to look for. All newborns are adorable, most of them. They're all squishy. They're little, their faces are squished, they're swollen. Moms who get IVs, you know, all that extra fluid goes up aboard with baby. It takes a few days for the little faces to not be so swollen. So that's kind of tricky in a brand new baby to tell. And so this little guy, you can tell mostly from his eyes. You can kind of see that he's got those epicanthial folds. He's got kind of the wide set eyes. They're very almond shaped. But I really want you to look at ears and neck on that picture on your right. You see the extra skin on the baby's neck? And do you see how flat their little neck is? I mean, you can almost draw a line up their, thoracic back, and then their neck and their head. It's not a nice curve with their little head coming out. That flattening, we can even see that on ultrasound. And sometimes when they notice some type of an abnormal neck appearance on ultrasound, they'll send you for like a bill of sampling or something to look for trisomy. But look at the little ears too. Those ears are low. I mean, super low.
At what stage can they pick that up on ultrasound? Because I have looked at that this time too, and they didn't have Down syndrome, but
yeah.
I didn't know.
At least 20 weeks, usually a little later. Yeah, baby's got be a little more developed for them to pick up any of those neck abnormalities.
Is that the only tip-off, really, you get when you
On
get
ultrasound?
pregnant? Yeah.
Yeah, that's
Okay.
most women they recommend to do blood testing.
Mm-hmm.
We reserve, the more invasive, like amnios and chorionic villus. We reserve those if something abnormal is picked up, and if the mom wants to do something about it. Like when I was pregnant, my husband and I decided not to even do the blood testing. I knew very clearly what my risks were, and I wouldn't abort the fetus if it was trisomy 21, and wouldn't really want to know about it if it was one of the other trisomies. So we chose not to do it. So it's optional. It's recommended, but sometimes medical providers don't do what we're told. So yeah, we chose not to do it, and everything turned out fine. But yeah, sometimes they can see that abnormal neck appearance. Now, there are some really clear 4D ultrasounds these days that towards the end of the pregnancy, they may be able to see some abnormal faces on ultrasound. But I had a kiddo just last year, saw the kid in the nursery, like very clear neck abnormalities, and the face was super swollen, but it really looked like Downs, and nothing had been detected. I mean, and this couple, it was their first baby. They were like mid-20s, so it was a blind sight for them. So yeah, it's still possible to miss Downs and have a baby born with it, even in this day and age with our good testing. Does that answer? Oh yeah.
Does the hair on the shoulder mean anything, or on the back there? Is that normal?
Yeah, so sometimes Downs babies are a little fuzzy, but many normal babies are really fuzzy too, especially my Hispanic population and Asian kids, very, very fuzzy babies. Yeah, lots of little lanugo, and it's dark, dark, dark. But they can have some abnormal hair patterns, so yeah, good catch on that. But okay, so look at that ear, and look at the very bottom of the earlobe. Do you see how low it is on their jaw? Feel your jaw. Do you feel the angle of your mandible, and you feel where your earlobe stops? And then feel up at the top how high your pinna comes up in line with your eyebrow. That is not a normal set ear. So when we talk about low set ears, there you go. All right, other things you're looking for when you see that little newborn, simian creases, those horizontal creases across the hand. Very common in Downs, also can be seen in chromosomally normal kids. My niece, who's 17, she's got a simian crease, but she's chromosomally normal, nothing wrong with her. So it's not completely diagnostic, it's just one of the things, it's also a board type question that you should remember. Short fingers are super common in these kids with trisomy 21. The most common heart defect, you'll hear a little heart murmur on most of these babies. They have a little atrial septal defect. Most of them close on their own, but some kids can have way more severe heart defects. So if you hear any murmur on a kid with Downs, get an echo as soon as possible. And here's the other big problem with kiddos with Downs. They're the happiest things you have ever seen in your life, but they're floppy, hypotonic, floppy babies. They're super delayed in their milestones. This little guy, that little guy's probably 9 months old, and he looks like he's not quite crawling yet. Most babies crawl around 6 or 7 months. So here's a story to help you remember the floppy baby. So probably 2 or 3 years ago, I had a student from that other program, and they were seeing one of my sweet little kiddos with Downs, and she was almost 1 at that time. Super hypotonic. So anyway, my student goes in, I'm sitting and chatting with the mom while she does an exam on the baby, and she has baby sitting up, which is great for most 1-year-olds, but not this baby. Well, she let her go, and the baby just went boom and flopped backwards, and the mom was like, nah. Mom was like, it happens. She does it all the time. My poor student was mortified. She thought she had really hurt her. But that's a good lesson to go, that with kids with Downs, you need to modify your physical exam approach because they have such low muscle tone. And that can be sneaky, so remember that. Let's see. All right, how are you going to manage these kids? Downs affects so many parts of the body that you have to be on the lookout for all kinds of weird things. Many kiddos with Downs have hypothyroid. A lot of them end up on some meds for their thyroid. Many kids with Downs have hearing issues. They need to be screened yearly for hearing testing. Because of those low set ears and kind of the abnormally shaped eustachian tubes into the sinuses, these kids get lots of ear infections. I think all of my Downs patients have ended up with tubes, which a lot of kids get tubes, my kid included, but all Downs babies end up with some type of a eustachian tube dysfunction. They need to see cardiology if they've got murmur, usually the ASD. If it's small enough, it tends to close on their own. By their couple, like second birthday, they tend to improve. But I have one little guy that he wasn't a TET baby, but he had some severe abnormalities. He ended up with open heart surgery, and it was because of his Down syndrome. Ophthalmology, the majority of kiddos with Downs end up needing glasses. They mostly have visual field defects. And then also neurology. Obviously, there's so many abnormalities. One of my little girls, actually the same baby that I was talking about that flopped over on the table, she started having bobblehead syndrome, which that's wild. Jot it down if you want to look it up for videos later. It looked like a little bobblehead doll. Like super awkward when you're looking at a baby and you're looking at the mom and you're going, how long has she been doing this? Anyway, so she ended up going to see neurology, which they did MRI, brain and brainstem, and everything was normal, but they just related it back to her chromosome abnormality, and sure enough, 6 months later, it resolved on its own. Here's the big one, leukemia. 12 to 20 times more common. Crazy bone marrow, crazy chromosomes, you're going to make weird cells. So these kids get a screening every year, white cell count, and just do a CBC and make sure you don't see any abnormalities. The key to helping these kids lead happy, healthy, productive lives is early intervention. And you're going to hear me preach that a lot, early intervention. The sooner you get these little guys to PT, I'm talking 2, 3, 4 months old, get them to PT. They will do once a week. Not only are they going to be going to PT, the beautiful thing about PT is those therapists are going to work with the parents and teach the parents how to help the child every day. So PT is not just about going 1 time a week and doing it once a week. It's about learning how to do the exercises daily to see the best improvement. Same thing with OT. OTs are going to help babies learn how to hold their bottle, crawl, transfer things from hand to hand. And speech therapists, they don't just help with speech, they help with feeding problems too. A lot of times these kids are really poor eaters. They don't have the hand-motor coordination to get food up to their mouth by 6 to 8 months of age, so they need lots of help. All right, let's move on to trisomy 13. These next couple of trisomies I'm going to talk about, these are not compatible with life. These are sick babies. This one's fairly rare, nearly always fatal. That's why, any picture you see that has a ruler next to the kid, it's usually not a good sign. It's usually, post-mortem type pictures. Numerous malformations. These are tiny, tiny babies. SGA is small for gestational age. Really small heads, microcephalic. We think this is probably, back in ancient Greek legends, we hear about Cyclops. They probably had seen infants born with the one eye, and it was probably trisomy 13. Cebocephaly, cleft lip and palate, super small eyes, or sometimes no eye development at all. Clubfoot, you can see the abnormally formed feet on the little picture of the fetus in the blue background picture. Multiple odd digits, polydactyly, malformations of genitalia, and really bad heart problems. These kiddos usually don't make it very long past birth. This is one of the things that they screen for on a amnio or blood work. They look for this trisomy. Trisomy 18, Edwards syndrome, slightly more common, but again, these kiddos do not last very long. I think the longest on record, was like 19 months, something like that. I haven't looked in a while. But modern medicine is making huge strides, so maybe someday we will have a cure and can help these babies live longer. Less than 10% survive till their first birthday. It's pretty lethal. Again, super tiny babies, unusual hand posture. You think when you see a newborn, what are their hands like? Closed, right? Closed hands. Look at that little guy in the bottom picture. You see that real awkward open hand position? And they hold their fingers weird. That's very odd ortho involvement. Those classic facies, they have those little bitty eyes, very common to have cleft lip, cleft palate. Very, very small head. And you can see, I like the picture on the bottom because you can see how abnormally shaped that little guy's head is, how low set that ear is, and how poor his muscle tone is. When you look at, he's got a big barrel chest, and he's got these little bitty tiny arms. Heart, intestine, and brain abnormalities is usually what leads to the incompatibility with life. All right, now let's talk about XY chromosome stuff. So this is going to be your more gender-linked issues. Let's talk about Klinefelters first. This is a little more common than you would think. These are males. They have a Y chromosome, so genetically they're considered male. But they have an extra X sex chromosome. So logically, what does that make you think? What are you going to see in somebody with this? Yeah, they're going to be more feminine looking, exactly. They're going to have a PD, but they're not going to look like a man. All right, so males are going to have really small penis and hypogonadism. You've got excess estrogen production in these people. You may see some more feminine features, like poor hair growth, narrow shoulders, wider hips, breast tissue, and a more female-type pubic hair pattern, which you have to do a really good thorough exam to start to notice this, but that's what you would see on an adult. By most point, adults are going to have been diagnosed a long time ago. Infertility, these guys are not fertile. And then it does affect cognition as well, so some degree of language and learning impairment. Initially, as a teenager or as middle school, adolescent age kids, these are tall, scrawny, long arms, long legs, and then they tend to gain weight as an adult and get a little bit obese. Scoliosis is really common, really abnormal gait, and really abnormal speech and developmental delays. So most of the time by elementary school, these kids are going to be in some type of an IEP program. They're going to have some identified problems in learning. So you're going to have some clue there. You can always ask the parent, how are they doing in school? Are they on an IEP? Do they have a problem retaining new information or learning new things? Management, so neurology can help out, endocrine can help out. They can do some testosterone replacement to help reduce some of those feminizing factors and help support, beard growth. And if you started early enough, then you can promote a more masculine appearance, less wide hips, more broad shoulders, more muscle tissue. And then there's support groups for people with Klinefelters because it is such a broad-reaching condition. It really affects every aspect of their life. So on the other hand, talk about Turner syndrome. These are females, but they only have a single X chromosome. Pretty rare. Again, we think 95% of Turner's fetuses are spontaneously aborted, but they just aren't compatible with life unless they make it. Some of them can't make it, but some of them do, and they continue in life to have some pretty serious problems. It also depends on if they're missing the entire second X chromosome or if they have part of a second X chromosome. And so there's some variability in the chromosomal hindrance to that. All right, so what do these little girls look like? First of all, they're really short. They have some growth problems. I like the picture of the little girl in pink. You can see she has a very webbed neck. Her skin folds for her neck come out like halfway behind her ears. And you can see that her width of her neck looks abnormally wide. Everybody got that? Okay. So hers is like a perfect example, but I want you to look at the little girl on the left. She does not have that same webbed neck appearance. If you look really closely, she maybe has a little extra skin towards the base, but that just goes to show variable penetrance, variable presentation. So just because they don't have webbed neck, don't rule that out. Prominent ears, sometimes it's because of the webbing of the neck, but you can see both little girls, their ears are pretty large and they stick out. And then they also have a very broad, they call it a shield chest. I don't have a great picture of it, but it looks wider than peers of their age. It looks more like they have like a shield under their clothing. And very triangular faces, so like from the forehead down to the chin is very triangular shaped. You can see they both have big smiley cheeks, but you can see they kind of have a wide forehead with a very pointy chin. All right, so there's a great picture of neck webbing too. I don't even know, that picture's gotta be from the 50s or 60s. Commonly, you hear, or they have hearing issues, so they need to be seen an audiologist. They might need some hearing aids. Visual and spatial perceptive disabilities. These little guys fall a lot, the little girls. They fall a lot, they run into doors a lot, they get lots of bruises, and they usually should never drive because they have some cognitive issues as well. They will have primary amenorrhea, they'll never start having periods because of the abnormal hormone balance, but they also have ovarian dysgenesis, so they're not fertile. You can, I think there's a slide in a minute here that talks about if they want to have a period, they can see endocrine or an OB and they can get on hormones. So their uterus will shed a lining, but they can't get pregnant. No ovaries, no pregnancy. Cognitive deficits are a big problem. We already talked about visual, spatial. Memory and math problems. Treatment, there you go, estrogen replacement, it'll make them have periods. I don't know why anybody would want to do that, but whatever. And then growth hormone therapy, if you can start it early enough, they can grow a little bit taller. They still will always be shorter than the average population, but that is something, that is an option if parents, especially parents are always concerned that their kiddo is going to be too short compared to their peers. Other abnormalities associated with Turner's, these are board type questions. Coarctation of the aorta, aortic stenosis, and horseshoe kidney. Remember those three with Turner's. Those are pretty common. All right, let's talk about non-Mendelian inherited disorders. So we were talking earlier, we went back to our genetics and we thought about Punnett squares and how things are Mendelian linked, recessive gene. Okay, these are not Mendelian linked disorders. These are maybe like de novo abnormalities that they arise spontaneously, but it's not an inherited type disorder. First, talking about Fragile X. Fragile X, it's an X-linked recessive, but not necessarily inherited. And it's the most common cause of mental retardation in males. Anything in bold on slides, typically you want to remember that. It's 1 in 1,000 male births, so it's pretty common, more so than you think. I have a few patients with Fragile X. Clinical features, this is full mutation. So again, this is one of those syndromes that can have a variable penetrance with a variable presentation. But with a full mutation, males always have an intellectual disability ranging from moderate to severe mental retardation. Notice on both of these photos, this little guy, he's got a really long face, really pale skin, rosy cheeks, blue eyes, and a really wide jaw. Do you see how his mouth and his teeth look kind of big for his head? That's something that we look for in chromosomal issues, is kind of an abnormally shaped jaw and teeth. Large gonads pre-pubertally, so if you're seeing a newborn on exam and maybe he's got very large testicles, if it's not hydrocele, then you should maybe think something chromosomal. Hyperactive, these kids get diagnosed as ADHD a lot of times. They get put on meds. The meds sometimes help, not generally. And a lot of times the kiddos, especially who have severe mental retardation, it'll appear as autism. They'll have poor communication, they'll have some difficulties with social skills, and it's not just autism, it's Fragile X. So anytime, this is good to know for whenever you're in peds or family. If you ever have to send a patient to the developmental pediatrician, she's gonna order CBC, CMP, and a chromosomal microarray and a lead level, because lead toxicity can affect mental cognition, right, and cause problems in kids. And so many males that have cognitive disabilities, it usually ends up being Fragile X. So go ahead and save yourself the time, get the lab before you send them to developmental peds. They can work on the diagnosis when the patient gets there. And MVP is mitral valve prolapse. Females can have Fragile X syndrome, but it does not affect them, right? We've got 2 copies of X chromosomes, so one is a little bit abnormal, we still got another one. So normal IQ to intellectual disability, so some females you may not notice, especially like in kids, they may not have an IEP, you know, they may be doing fine in school. But many times in females this presents more as behavioral problems. It might look like autism. You might have a lot of anxiety issues in these little girls. I mean, this is like, 5-year-olds who like cries every day when their parent tries to drop them off and cries for like an hour. Most kids, you get them to school, you go, 10 minutes later they're fine. These are the kids that do not do well in group settings in school. Very shy. Attention disorders, sometimes they'll wander around the room and the teachers will say, oh, I think they have ADHD. Well, no, it's more of a chromosome issue than ADHD. And they're at risk for affective or schizophrenia spectrum disorders. So it's interesting the way that it presents in females versus males. Management, these kids all need to go to OT, get some help figuring out how to do things a little differently in life. A lot of times we'll need some PT to help with any motor dysfunction. Behavioral interventions, kiddos who have autistic-like tendencies, parents typically need some help learning how to work on discipline with them. A lot of times we see seizures in these kids, so neurology if they have any type of neurological issue, and then if they've got mitral valve prolapse, obviously they would be seen for Okay, now let's jump back to some Mendelian inheritance. These are traits that can be inherited with the pattern. Marfan syndrome. So when you think Marfan syndrome, I want you to think super tall, gangly looking, hunched patient. That's if you have a patient walk into your clinic, that's what they look like, think Marfan's right away, okay? So Marfan syndrome is going to affect skeletal, ophthalmologic, and cardiovascular systems. So like we talked about earlier, get x-rays. If it looks odd on the outside, probably something going on the inside too. These people with Marfan's definitely need some chest x-ray, spine x-ray, look for abnormalities, and a good ophthalmologist to follow up with them. Many times they'll have heart defects. Most commonly, in the one that's a board type question, aneurysms. That's what's going to kill them, is a dissected aortic aneurysm. Not much you can do about that. So what do? You detect it early, and you do everything you can to prevent it from dissecting. They can have aortic aneurysms as well, floppy valves, they may have a heart murmur, you may get a chest x-ray, and they've got cardiomegaly, obviously get an echo and send them to cardiology. Super tall, and then pes excavatum. You guys, you've done your ortho, so you've seen that kind of like hollowed out shape that the sternum can take on. Okay. And hand connective tissue abnormalities. So because of that, we can do all these crazy tests. Here we go. Marfan syndrome hand testing. You guys can do some of these on yourself if you want. So depending on, wingspan and looking at how mobile your joints are, and can you wrap your entire hand around your wrist? Can you pull your skin on your fingers? I can't do that. Can you bend your thumb all the way back to your forearm? Anyway, so these are all connective tissue things. If you have the patient bend over to do a spine check, can they bend over and put their hands completely flat on the floor? I would expect a gymnast or ballerina to be able to do that, but most teenage guys probably are not going to be doing that unless they've got Marfan's. So anyway, that's a scoring system you can use. If you need to get them to genetics to get a confirmation for Marfan's, you can do this in your exam and put it in your note. All right, let's talk about neurofibromatosis. This is a chromosome 17 abnormality. There are several types of neurofibromatosis, but this one specifically deals with chromosome 17. It presents as an infant with cafe au lait spots. You guys talked about that in your newborn exam? Okay. Cafe au lait spots in a newborn are not normal. I mean, like, I've seen one that it turned out to be none, especially if as they grow, they keep getting more. That's really not normal. Start to think chromosomal stuff if you see, like, Ashley spots and cafe au lait spots. If they have more than 6, by the time they're a year old, they need to go see a geneticist, and they need a chromosomal microarray done. Neurofibromas are these very odd little deposits of connective tissue that they get these little tiny tumors all over their skin. And by the time they're adults, it can be pretty serious. You guys can look up all the pictures you want. It's more common than you would think. They get those Lish nodules. They usually have a lower IQ with this condition as well. The picture of the Lish nodules in the eye, I just think that's amazing that you can get such weird connective tissue deposits in weird places. Anyway. All right, chromosome deletions and alterations. Let's talk about 5p deletion. This is Cri-du-chat. You all heard of this one before? Okay, good. It's a little bit rare. It's I was looking up stats last night, 1 in 50,000. So the odds of you ever seen it are pretty rare, but it's out there. It's actually slightly more common in females. I know the photos I've got are of a little boy, but because you see these pictures, don't think, oh, it's only male. It's actually a little more common in females. It's called, anybody speaks French? Yeah? Yeah, Cri-du-chat. So especially when they're little, their cry sounds like a kitten. I tried to find a recording for you, I couldn't find it. But anyway, so that's one of the most diagnostic. When you hear a newborn in the nursery that has some abnormal sounding cries, if there's something going on with their vocal cords, maybe better think chromosomal abnormalities. Most cases arise de novo. It's a spontaneous type mutation, not inherited. These are little bitty kids, very, very small. FTT is failure to thrive. So as the kid is getting older, they grow really, really poorly. And there's very characteristic faces. And I love, this is a progression of a little guy with Cri-du-chat. You can see him, I think in my notes it says he's like 8 months, 2 years, 5 years, and 9 years in those pictures. And you can see as an infant, he didn't have cleft lip palate, but that's very common. Hypertelorism, that means wide spaced eyes. So you can kind of see in a newborn, he's got extra space kind of on the side of his nose that you would not expect to see in a little guy. Downturned palpebral fissures over the eye, and again, those low, funky-looking ears. There you go. Ears are very common. And these guys all have different levels of developmental delays and mental retardation. Beckwith-Wiedemann syndrome is a chromosome 11 problem. 1 in 15,000 live births. I have a patient with this. He's one of my favorites. He's so sweet. So this is a clinical condition that these babies are born big. My little guy that has it, he was about 10 pounds when he was born. Super big. And they just don't look like little newborns. Their body, they come out looking like a 2 or 3 month old. Their muscles are more developed, they're chunky, they've got a big belly. They just don't look tiny. And here's where it gets tricky, because some kids whose moms have gestational diabetes, especially that's uncontrolled, they'll come out super big too. I mean, you hear about, Australia had a woman with a 12-pound baby. She probably got gestational diabetes. And those babies, after they're born, they can't regulate their glucose like a healthy mom without diabetes can. So many times we see their glucose levels tank. They drop into like the 30s and 40s. So we have to, if they're not breastfeeding, well, if they are breastfeeding, we have to give them a little bit extra formula to help keep their blood sugar stable, and they have to check them very frequently in nursery. So this kid would be a big baby whose mom did not have gestational diabetes, who is having hypoglycemia in the nursery. It's very odd to see that. Creases and pits, and then asymmetrical limbs, that tends to happen as they get older. They may have one side of their body grow at a slightly different rate than the other side. Organomegaly, they may have a big liver or a big spleen. The biggest thing on the exam that you'll notice right away with an infant, macroglossia, that big old tongue. I know congenital Downs is one, or congenital hypothyroidism is one thing you think of. Downs babies have their little tongue that sticks out of their mouth a lot. Beckwith-Wiedemann babies have a tongue they just hang out of their mouth. And omphaloceles are really common in these kids too. There's a little guy with an omphalocele. This is pretty big. Good size omphalocele. So the problem with Beckwith-Wiedemann is it leads to an increased risk of Wilms tumor and hepatoblastoma. So these kids will start seeing a geneticist, and the geneticist is going to order a AFP lab every 6 months and a liver ultrasound every 6 months on these babies. So my poor little guy, they go a lot to the lab. They know them very well there. But I wanted to, in the picture, the middle picture, the green background, that little guy, big tongue, you can't really see his teeth, his tongue is hanging over it, and he's got kind of the pits and fissures in his earlobe that's very abnormal in a kiddo. And he's big. I mean, there's a lot of kids out there that genetically, parents may be bigger people, and you look at the kid and you're like, oh, he looks just like his daddy. But these kids, from birth, you just never say, oh, they're so tiny. They just never look tiny. Okay, let's talk about bilocardiofacial or DiGeorge. There's several names for these syndromes. That catch 22 on there, that's an acronym used to talk about cardiac, abnormal facies, thymic dysplasia, cleft palate, hypocalcemia, all related to chromosome 22. So if you hear that term, think bilocardiofacial or DiGeorge, but know that the terms are kind of all interchangeable, and they all have kind of a variable presentation, but it's a similar unit of chromosomal abnormalities. I've got a kid with this too, so he presented, interestingly enough, the kiddo that I take care of with this, he looked just like his mom. Mom had the exact same features, and when I saw them the first time, I was very delicately saying, okay, well, tell me about your medical history. Have you ever been diagnosed with any heart problems, metabolic disorders, genetic problems? And the mom was like, no. I'm thinking to myself, okay, something's not right here. So the little guy, he had severe speech delay. I started seeing him when he was like 18 months or 2, somewhere around there. And he's 5 or 6 now. He's done really well. But these kiddos all have some degree of learning disability, developmental delay, especially speech and communication problems, and they all have this very classic appearance. Okay, so your philtrum, your little ridge right there, right above your nose, these kids just don't have one. It's flat as can be. Super thin upper lip. This picture of this little guy shows like he barely has any visible. Really low set ears, again, there's the ears, and wide set eyes, that hypertelorism we've talked about. And they can also have heart defects, so it's important to listen for a murmur. My little guy did have a murmur. He had a really small ASD that has gone away in its own time. Prader-Willi, this is a really interesting condition. This is a chromosome 15 abnormality. 1 in 25,000, so rare, but it's out there. And it's a growth hormone deficiency problem. So what's interesting about Prader-Willi, and what I want you to remember, these kids start out as failure to thrive, but are going to end up obese. Isn't that ironic? These kids are tiny as kids. So prenatal to birth, decreased fetal movements, lower birth weight than any of their siblings. They're real small looking. As they grow, they're hypotonic, kind of like Down's kids, but they don't have Down's facies. They may have a decreased appetite, and they may be really poor feeders. So they gain weight really poorly. And then as they get a little older, things get better. They start growing appropriately. But by the time they turn 2-ish, they start to get obese without any extra calorie intake. And then by the time they're adults, the really interesting thing about Prader-Willi is these people cannot stop eating. You literally have to lock food up to keep them out of it. There you go. Start off scrawny, end up as obese. So we talked about the hypotonia in infancy, really small hypogonadism, small hands and feet, almond-shaped eyes. Obsessive hyperphagia is the hallmark, and that starts as a toddler. All toddlers have favorite foods and like to eat, but these kids, they will eat everything. They'll eat dog food, they'll eat gravel, they'll eat trash, they'll eat everything because they are constantly hungry. Clinical features other than the weight, mental retardation, most of them have some degree of an intellectual disability. Short in stature, it's a growth hormone problem, right? So strabismus is really common. If you can kind of tell, it's kind of hard to see, but on the left when this guy was small, can you see strabismus? His little eyes are a little wonky. And then complications of it, type 2 diabetes. I mean, gosh, if you eat and are obese, you're probably going to get diabetes. Pickwickian syndrome is respiratory difficulty because of weight. So remember your little fridge with the lock on it. Symptoms of Prader-Willi, they cannot stop eating. But we do have good treatment with endocrinologists and geneticists. They can use growth hormone substitutes to help. And so I love this picture of, you know, this guy at 0 months and then 5 years out. He's done so well on growth hormone treatment. And it really helps change their metabolism so that they don't have the obesity and the risk for type 2 diabetes or respiratory problems. All right, Angelman's. This is an interesting condition, probably more common than you would think. Also on chromosome 15. And we think it's about 1 in 15,000, but some instances say 30,000. These kids usually get diagnosed between ages 3 and 7. So usually like preschool or early elementary age, we start noticing that something's not right. As an infant, they may just seem a little bit delayed in their development, but then we can see as they get older, they get more delayed and they have more complications. So you can look at the facial features there. These kids, again, that kind of really large mouth and really wide set teeth, really small chin, a large lower lip, and then they have this little sunken nasal bridge, so their nose will stick out drastically. Their bridge will be sunken down in. Let's see what else is on there. Oh, and then the blue eyes. That's also a really common feature. Coloring is an interesting thing to look at in Angelman's. It's not diagnostic though. There's plenty of kids with brown hair and brown eyes that have Angelman's. So these kids, there's a term, some people call these kids the happy puppet kids. These are kids who laugh all the time, even sometimes at inappropriate times, like when they're hurting they may laugh. They're super happy, hardly ever cry, nothing gets them down, which as a parent may seem great until you see other kids and you're like, my kid never has a tantrum, that's probably a little odd, or my kid never cries when I don't give them something, that's a little odd. And they're having lots of developmental delays, like they're not walking by a year of age, not saying words, not talking. They may make sounds, but they aren't babbling and following that typical pattern of speech that we see. Seizures are very common in Angelman syndrome. And then the paroxysmal laughter, which as a parent, I'd much rather hear my kid laugh all day than cry, but there comes a limit where you're like, okay, something's not right here. And excitable personality. Some teachers will say, well, I think they have ADHD, but no, really it's just they're excitable. So clinical features, sometimes they do some tongue thrusting behaviors. We talked about the seizures. So the puppet-like gait is really interesting. Once they do start walking, which is usually delayed, as toddlers, they will hold their hands out like this. They'll hold their arms out really wide, and they'll pick up their legs like a puppet would. There's some really good videos, like on the Angelman's Foundation website. There's a really great video about a little girl and her process of how her parents noticed something was wrong. And anyway, if you wanted to see more about it, feel free to look it up and watch the video. It's like 6 minutes. Abnormal posturing. These kids, because of their low muscle tone, will sit funny or stand funny or lay on the floor in kind of weird contorted positions. Strabismus is really common. They'll be needing to see an ophthalmologist. That prognathism, we were talking about, jaw problems, and so their jaw may be slightly forward. And these kids with Angelman's, they all have sleep problems. It's part of how their brain is, dysfunctioning. They just do not sleep well. Most babies, you hear parents complain, oh, my baby never sleeps. This kid seems to never sleep. Like in the video that they have on the Foundation website, they were talking about their daughter, even at like 6 months old, she would nap in 20-minute increments, and she would only sleep like 2 hours at night. So very abnormal sleep patterns. Oh, do you recognize who that is in the picture?
Colder.
Yeah, his son has Angelman's. So management of these kids with the seizures, they're gonna need to see a neurologist for med management. All of those gait problems, they're gonna need PT, probably an orthopedist for some insoles, maybe some bracing, occupational therapy to help them learn how to do things a little differently than other kids, and definitely a sleep specialist. Ugh, I think having a kid with Angelman's, I think the hardest part for me I would imagine, be the lack of sleep. I mean, because these kids want to be up playing and you're just like, please go to bed. So yeah, sleep specialists can help with that as well. All right, there are some references for you. Any questions? No questions? Okay. Well, okay, let's take a bathroom break.